Welcome viewers once again in our teleconferencing program. This is the third session of our today's teleconferencing program. The topic of today's program of this session is echocardiography in mitral stenosis. To give you information about this particular topic, we have with us in our studios Dr. Sangeeta Sachdeva. I welcome again Dr. Sachdeva. And viewers, if you want to know anything about this particular topic, echocardiography in mitral stenosis, you can make a phone call in our studios for your queries. Our numbers are 29532844, 29532845 and toll free number 1800112345. One more thing I would like to remind you that if you download the forms, you can go to our website, that is www.netboard.edu.in, www.netboard.edu.in. You can avail DVD of this program from National Board of Examination. This program is jointly conducted by Indira Gandhi National Open University and National Board of Examination. Once again, I come to you, Dr. Sachdeva.
Thank you very much. So I'm back again. This time I'm going to be talking on echocardiography in mitral stenosis. Mitral stenosis, the echocardiography is the most sensitive and specific non-invasive test for characterization and periodic assessment of mitral stenosis. It gives a comprehensive assessment of the left ventricular function, valve morphology, valve hemodynamics and the pulmonary pressures. A normal adult mitral valve area, which I will be calling MVA after this, is roughly 4 to 6 centimeter square in cross-sectional area. A mild mitral stenosis would be a patient with an MVA of 1.5 to 2.5 centimeter square. Moderate mitral stenosis we call when an MVA is of about 1 to 1.5 centimeter square, and you have severe mitral stenosis if the MVA goes below 1 centimeter square. As the valve area decreases, the hemodynamic perturbations become more significant. As valve area decreases to less than 2 centimeter square, an increase in the left atrial pressure is necessary for the normal transmitral flow to occur. And a symptomatic mitral stenosis develops when the MVA falls to less than approximately 1.4 centimeter square. And at a valve area less than 1 centimeter square, and left atrial pressure of about 25 millimeter mercury is required to maintain a normal cardiac output. What are the etiology of mitral stenosis? Very commonly, which we see in India, rheumatic heart disease, degenerative calcification, massive mitral annular calcification, large vegetations on the mitral valve, congenital malformations, inborn errors in metabolism, carcinoid syndrome, systemic lupus erythematosus, rheumatoid arthritis, amyloidosis, hypereosinophilia and Caffrey-Gott toxicity. In a M-mode echocardiography, what do you see in a patient? The M-mode echocardiography is cut through the base of the mitral valve, of the stenotic mitral valve, and it will demonstrate increased echoes from thickened, deformed, calcified valves, leaflets, decreased opening amplitude of the valve, and anterior motion of the posterior leaflet, a decrease in the initial diastolic leaflet closure. The initial leaflet closure, that is the EF slope, and EF slope less than 10 millimeter second indicates severe MS, and left atrial enlargement is usually also readily apparent on M mode. And mitral valve alveolar calcification can also be detected on M mode. Now here you can see the M mode picture of this patient. Here you can see that the mitral valve, the PML is moving anteriorly in diastole. There is thickened leaflets as well as the EF slope is decreased. This is a clear-cut M mode picture of a patient of rheumatic stenosis. In a 2D echo, the rheumatic mitral stenosis is typified by diffusely thickened calcified valve leaflets. The thickening and calcification begins at the tip of the leaflets and progresses towards the annulus. The commissures appears fused and there is both shortening and fusion of the chordae tendineae. This is characterized by a hockey stick or a diastolic doming appearance of the anterior. This is a rheumatic heart disease of the anterior mitral leaflet during diastole, or an abrupt restriction of motion of the leaflet is not pliable. An immobile posterior leaflet and a fish mouth appearance of the valve in the parasternal short axis view, and left atrial enlargement with possible thrombus can be seen. So here you see a doming AML, PML movement moving anteriorly in this patient of mitral valve stenosis. Here again you can see, this is how you're seeing the section. This is the AML, this is the aortic valve. This is what I told you in the previous lecture, this is a parasternal long axis view. The PML is also moving anteriorly, AML domes in diastole with the PML moving anteriorly, restricted opening of the mitral valve and a thickened mitral leaflet. Here again you can see the subvalvular apparatus, which is again thickened. This is the subvalvular apparatus, the AML, PML, and a thickened subvalvular apparatus, which is seen very well in 2D. This again a patient with mitral stenosis. You can see the thickened subvalvular apparatus, mild calcification. This patient has marked calcification of the mitral leaflets on the tips, but the leaflet is pliable. In spite of the tips being fixed and thickened and calcified, the leaflet was still pliable in this patient. In patients with concomitant mitral stenosis and mitral valve prolapse, there will be a diastolic doming. In patient, the AML will dome in diastole, but there will be a systolic prolapse of the anterior mitral valve leaflet, can be identified in the parasternal long axis view. While in patients of severe mitral annular calcification, that can also lead to mitral stenosis, as I showed you in the etiology. But in contrast to the rheumatic mitral stenosis, the calcification begins at annulus, while that in rheumatic always begins at the tip. So that begins in the annulus and spreads towards the tip, and that in rheumatic starts from the tip and spreads towards the annulus. Patients with severe AR may cause effective mitral stenosis by restricting the motion of the anterior mitral leaflet and will lead to diastolic fluttering. When you see all the M mode and the subvalvular apparatus, and the calcification which is present, as well as the thickening of the valve, there are certain grades which you give, and out of these 16 you grade the anatomical. There is a classification of mitral valve which is by the form of which is classified and shown you how you do it here. Leaflet mobility, when it is highly mobile valve with restriction of only the leaflet tips, you give it a grade 1. And mid portion and base of leaflet have reduced mobility, grade 2, and so on and so forth. You grade it from 1 to 2 to 3 to 4. 4, there will be no or minimal forward movement of the leaflets in diastole. Coming to valvular thickness, if leaflets are near normal, that is about 4 to 5 millimeter, is grade 1. Then mid leaflet thickening and marked thickening of the margins, grade 2, and grade 4 is marked thickening of all the leaflet tissue, which is more than 8 to 10 millimeter. Then you evaluate the subvalvular apparatus, subvalvular thickening, minimal thickening of the caudal structures just below the valve, you give it grade 1. When it is thickening of caudal extending up to 1/3 of the caudal length, 2, and extending up to the distal third, grade 3. And when there is extensive thickening and shortening of the whole of the chordae extending down to the papillary muscle, you grade it as 4. Valvular classification, grade 1 is a single area of just increased echo brightness. When the scattered areas of brightness confined to the lateral margins, you give it grade 2. And when the brightness is extending to the mid portion of the leaflets, is grade 3. And when there is extensive brightening through most of the leaflet tissue, it is grade 4. So once you evaluate the valve in M mode in 2D and you grade it according to these different of leaflet mobility, the thickening of the valve, the subvalvular apparatus, and valvular calcification, and you grade it as per 8/16 or whatever is the score of the valve. Now, in patients of congenital mitral stenosis, it's a rare disorder and it has a variable appearance. You may have patients with parachute mitral valve, which is connected just to a single large papillary muscle. The single or a dominant papillary muscle is recorded in the center of the left ventricular in a short axis view. The supravalvular mitral ring can also be present, which is also known as a membranous supravalvular mitral stenosis. Is another congenital malformation which results in effective mitral stenosis and is frequently associated with other anomalies. In this condition, a membrane appears in the left atrium at or slightly above the mitral annulus and may be associated with an obstructive gradient across the mitral valve. Here in this patient, you can see a single papillary muscle to which both the leaflets are attached. Here you can see it on short axis, the dominant papillary muscle here, which is normally you see as 2. This is a big single causing a parachute mitral valve. This is a patient with supravalvular ring. This is seen here, and this is where you are seeing the supravalvular mitral ring, which causes effective mitral stenosis across it. Similarly, here you can see this membrane here. You can see it out here in the 2D also. Functional mitral stenosis can also be caused by left atrial tumors, by cor triatriatum, thrombus, infective endocarditis where there is a very large vegetation and it causing functional stenosis, or in patients with severe MR where there is increased flow across the valve. Now, the planimetry of the mitral valve is performed in the parasternal short axis orientation with the plane of the transducer parallel to and passing directly through the valve orifice. As we discussed when we are seeing the parasternal short axis view, when we go down, you go at the mitral valve level, and the first time when it's passing directly through the valve orifice, that is where you have to measure the mitral valve area. The smallest orifice area during maximal diastolic leaflet separation is recorded by tracing the fish mouth orifice. MVA determined by planimetry is not significantly affected by changes in heart rate or cardiac output, but is subject to several other potential limitations. What are the limitations? The technique is largely operator dependent. If you don't go at the tip, you go somewhere below it, you may get a larger valve area. Proper alignment of the imaging plane relative to the valve orifice is critical. Improper alignment may make the orifice appear larger than it actually is. The orifice should be measured during initial diastole when the valve is maximally distended. Selecting an orifice recording after valve closure has begun will result in falsely lowered mitral valve area. Appropriate receiver gain settings are necessary to prevent over or underestimation of the orifice area, and low transducer frequency can result in loss of resolution, while high transducer frequency can cause loss of penetration. The orifice should appear fish mouth. Good lateral resolution is necessary to identify the medial and the lateral margins correctly. Extraneous echo-free areas caused by shadowing or dropouts may be mistaken for valve orifice. And planimetry has decreased accuracy in setting of valvular thickening and marked calcification, chest deformities, and a previous commissurotomy procedures. So here you see the short axis view. We normally calculate the MVA from here. This is the mitral valve orifice. We take a trace right through this, and this is where we calculate the MVA by 2D. After getting the right view at the right place, then only you get the right result. This is again planimetry of a patient. It's not a very good window, you can see, so you may not get the right calculations. This is a patient with calcification. The marked calcification, here you're not able to really see the orifice, so here it may be difficult. Here still you can decipher the orifice and be able to calculate, but in this patient 2D planimetry may not be possible. The apical 4-chamber view is ideal for determining the position of the AV ring, the point of mitral valve insertion, and the point of mitral valve closure. Assuming that the mitral valve orifice is elliptical, one can estimate the mitral valve area from the maximal diameter of the color flow stream through the mitral valve area in the apical 4-chamber and a plane rotated roughly 90 degrees using the equation MVA is equal to pi upon 4 into AB. The advantage of this approach is that the calculated valve area will not be influenced by mitral regurg or aortic insufficiency. As with planimetry and all other forms of calculated valve area, the gain has to be set appropriately. So here again you can see a 4-chamber view of a patient of rheumatic heart disease. AML is doming, PML movement is restricted, slight calcification on the tips. This is the subvalvular apparatus. Of course, we are not seeing it completely. That would be seen in other views. But this is what you will see, a dilated LA. So you get the entire picture in this. Of course, in this patient, you will also see that the tricuspid leaflets are also thickened. But we are not going into this in this study. This is another patient, absolutely very thickened and calcified mitral leaflets. Very, very tight valve. The color flow is not here, but there is a thin jet out here through these leaflets. It is a patient of severe mitral stenosis with marked calcification. So how does Doppler echocardiography help you in patients with mitral stenosis? Doppler and color flow echocardiography are used to calculate the mitral valve area using the continuity equation, pressure half time, and proximal isovelocity surface area, which is called the PISA methods. All available windows are used to obtain the Doppler signal, which is most parallel to the direction of blood flow, since the angle between the sampling beam and the vector of flow will affect the accuracy of the formula. This is a basic of Doppler. You have to be parallel to the flow. Hemodynamic variables should be averaged over at least 5 cycles in patients in sinus rhythm and more in patients with atrial fibrillation. Mitral regurgitation causes underestimation and aortic insufficiency causes overestimation of mitral valve area by the contamination of the mitral flow stream with higher velocity flow. The flow velocity and pressure gradients vary with cardiac output. So patients with a low cardiac output or a bradycardia, you may have low mean gradient, though there is a severe mitral stenosis. Similarly, patients who have got increased cardiac output and heart rate, there will be an increase in transmitral gradient, left atrial pressure and pulmonary artery pressures during exercise. Increases in cardiac output and will cause an increase in them. Mean transmitral gradient can be used to estimate the severity of mitral stenosis. A mean gradient less than 5 mm mercury indicates mild stenosis. Mean gradient between 6 to 12 indicates moderate stenosis, and a mean gradient greater than 12 indicates severe stenosis. This is the Doppler continuous wave across a mitral valve. In normal, you will see the EF slope. This is how the EF slope is. The gradient is less. This is a turbulent flow across the valve. The velocities are more. There is a decrease in the EF slope. All these features, and then I'll be discussing about the pressure half time and how this will help in calculation of the mitral valve area in those patients. Color Doppler through the stenotic mitral valve demonstrates a turbulent flow with central aliasing. The more parallel the transducers to direction of the flow, the more aliasing can be demonstrated. Color flow helps direct the sample beam to minimize errors associated with Doppler measurements. Here you can see aliasing. There's a stenosis. This is the mitral valve, and you can see this turbulent flow in color, which is aliased flow, which is seen in the center. So how do you calculate the MVA by pressure half time? The pressure half time, what is pressure half time first of all, is the time it takes for the transmitral pressure gradient to decrease to 1/2 of its original maximum early diastolic value. It is measured from the continuous wave transmitral spectrum. Pressure half time is prolonged in the setting of mitral stenosis, and it is not affected by heart rate, by cardiac output or by regurgitation. A normal range of pressure half time is normally about 20 to 60 milliseconds. Patients with mitral stenosis have pressure half times of greater than 90 milliseconds, and a pressure half time greater than 22 milliseconds indicates severe mitral stenosis. MVA is calculated by 220 upon the pressure half time. That is the formula which is used, and once you take that, you can obviously know when it is 220, the MVA will be 1, and less than 1 is severe mitral stenosis. So here you can see a patient, this pressure half time was 183. You calculate, you put the probe out here, you calculate the pressure half time, and that is 183, and the MVA is 1.2. In this patient it was 0.8. You can see also that the EF slope is also changing, and this patient's pressure half time was 366, and this mitral valve area was 0.6 centimeter square. So you can see the difference in the pictures of the patients with a 1.2 valve and those with 0.6. Now there is also mitral depressurization time or deacceleration time, which is actually the same thing as you talk about pressure half time. This is proposed to be the slightly faster and more accurate means of estimating MVA than pressure half time. But now with the new machines and all, pressure half time is the one which is normally used. But still, I'm just mentioning it. MVA is equal to 750 upon AC, which is the mitral depressurization time, where AC is the time taken from a line drawn from the peak velocity profile along the slope to reach the baseline. A depressurization time of greater than 750 milliseconds indicates severe mitral stenosis. Actually, if you calculate the deacceleration time, it takes about, it is about 29%, this is about that 1/3. It takes about 30% may the pressure half time is reached. So this is similarly a fallout of the same thing when you calculate the pressure half time or you calculate the mitral depressurization time. A depressurization time of greater than 750 milliseconds will indicate severe mitral stenosis. Pressure decay across the stenotic mitral valve is dependent on net AV compliance as demonstrated by Thomas et al. Pressure decay measurements will also be influenced by the maximal transmitral gradient. Therefore, the pressure half time and mitral depressurization times are not accurate for patients who have MR, aortic insufficiency or recent balloon mitral valvuloplasty. Another method of calculating the mitral stenosis by Doppler echocardiography, the MVA by Doppler, by quantifying it, is the continuity equation. What is it based on? It is the law of conservation of mass and energy, which states that the flow, let's call it Q, which is equal to the velocity time across cross-sectional area, is constant at different points in a tube. So the flow across LVOT will be the same as the flow across the mitral valve. So you know the LVOT area, you know the VTI across the LVOT valve, and you know the VTI across the mitral valve. So you can calculate the mitral valve area. So what you do is you calculate the radius of the LVOT, pi r square is the LVOT area, multiply it by the VTI across the LVOT, divided by the VTI across the mitral valve, and you will get the mitral valve area. But this assumes that the flow across the two areas is the same, which is not the case in patients with mitral regurg or aortic insufficiency. So this method estimates the effective orifice area rather than the anatomical orifice area. Then PISA, or the proximal isovolumic surface area. The proximal isovelocity surface area, which is called PISA, or flow conversion method of calculating MVA, relies on the assumption that flow accelerates radially in series of hemispherical shells towards the vena contracta, which is the vena contracta is the narrowest point of a stenotic orifice. The first Aliasing boundary, where the velocity reaches the Nyquist limit and the color Doppler changes as flow begins to accelerate towards the stenotic valve area, is identified in the apical 4-chamber view, and the peak distance from the orifice to the boundary is measured at a low Aliasing velocity. You have a color scale, and if you see an echo machine, you come to a velocity at which there is Aliasing below, just before the mitral valve orifice, and that velocity is taken. Then the radius is taken. Selection of appropriate Aliasing velocity is important to prevent over or underestimation of valve area. Low Aliasing velocity results in increased distance from flow conversion region to the stenotic valve, and therefore it will be reducing and reduce measurement error. The flow through the isovelocity hemisphere is equal to the surface area, which is multiplied by the Aliasing velocity. So we get the Aliasing velocity. Now we have to calculate the surface area. The area of a hemisphere is the maximum PISA. The factor that accounts for that inflow funnel angle formed by the mitral leaflet is the funnel angle, which is alpha, is divided by 180. So you have to know the funnel angle, you have to know the radius, the maximum radius of the PISA. So what variables do you have to know? You have to know the velocity, the Aliasing velocity, and you also then have to know the velocity, maximum velocity across the mitral valve. Flow rate of the hemisphere is described as Q, and this is the formula, 2 pi r square upon alpha 180 upon the Aliasing velocity. And again, as we talked about the law of conservation of mass and energy, the flow through the isovelocity hemisphere is equal to flow through the mitral valve. So mitral valve area will be equal to this Q upon the peak velocity across the mitral valve. So simplified, it is 2 pi r square, the radius of the PISA, the angle upon 180 into the Aliasing velocity upon the peak velocity. This is what I was talking about. If it was sounding a little complicated, this is the mitral leaflet. This is where I have taken the picture. This is where once you decrease the velocity, Aliasing occurs somewhere here. So we measure the angle out here, which is the angle theta. Measure, this is called this is the radius. This is the radius, and after measuring this, and you have the velocity, when you take the gradient across it, you take the maximum velocity, and you can calculate the MVA by proximal isovolumic surface area. Traditional two-dimension PISA is limited by low frame rates, which makes it difficult to simultaneously measure both mitral velocity and flow. They have recently described an alternative method of measuring flow conversion using color mode, which allows higher sampling rates and more precise timing of measurements. What they did was they placed the M-mode cursor line through center of the flow conversion areas and recorded peak radius of flow conversions during 4 phases. They obtained phased match transmitral velocities from continuous wave Doppler and recording of cycles with identical diastolic duration, and calculated the MVA separately for each phase. So you can see this is an early diastole, then this is different stages of diastole. Similarly, this is the velocity at different stages, early, little, mid, late, and similarly this is the M mode, and then you measure the radius from here different places and calculate the MVA the same way as we have mentioned before. Then there is another way we calculate, which is called vena contracta width. The vena contracta is the narrowest point of flow through the stenotic mitral valve. Vena contracta width has been recently proposed as a tool for evaluating mitral stenosis. They measure the vena contracta width and use the formula to calculate MVA. Here MVA is equal to pi r square, where r is equal to the vena contracta width upon 2. It's quite simple. The vena contractor width method of calculating MVA correlates well with the planimetry, pressure half time, and the Gaulian equation in patients who undergo right heart catheterization. Now you got tissue Doppler imaging also now in all the labs in big centers at least. So in tissue Doppler images is recently developed, it's not very recent now of course, which allows for the measurement of myocardial tissue velocity. In an analysis of myocardial velocities in patients with pure mitral stenosis, it was found that a significant reduction in the left ventricular myocardial velocities in study patients was seen when compared to healthy controls. Mean left ventricular systolic mitral velocity, which is SM, and early diastolic velocity EM and late diastolic myocardial velocities AM were all significantly reduced in patients with mitral stenosis, while right ventricular myocardial velocities and the EM upon AM ratio at the tricuspid annulus were not significantly different from the controls. They also found that the left and right ventricular myocardial perfusion indices correlate with the pulmonary artery pressures in patients with mitral stenosis. Myocardial perfusion indices are the isovolumic contraction time, the isovolumic relaxation time. You add the sum and divide it by the ejection time, and that you see this correlate well with this also. The Gaulian's formula which you use with catheterization, they have seen that this is the which we use for the direct measurement of transmitral gradient and cardiac output during catheterization to calculate the MVA, and many echocardiographic methods of MVA have demonstrated to correlate well with catheterization derived MVA, including planimetry, pressure half time, and PISA, because these are the three most important methods. The others I've just touched upon so that you know about it. Stress echo in mitral stenosis. Exercise and dobutamine stress testing have been performed in catheterization laboratories and in association with echocardiography in patients with discordant severity of symptoms and MVA or transmitral gradients at rest. Patients with no or mild symptoms attributable to mitral stenosis who develop dyspnea during exercise or dobutamine stress echo have been found to have larger increase in transmitral pressure gradients than those who do not develop dyspnea. The presence of dyspnea during dobutamine infusion has been demonstrated to be highly specific for and predictive of significant mitral stenosis. Baseline pulmonary artery pressures, mitral valve area, and subvalvular echocardiography score were found to correlate with the increased transmitral pressure gradient. Patients who develop symptoms and elevated pressures during exercise or dobutamine are felt to have significant mitral stenosis requiring intervention despite discordant MVA. Mohan et al. Have demonstrated that MVA is determined by both planimetry and PHT methods increases with an increase in flow rate across the valve during dobutamine infusion. The magnitude of the increase, however, was not clinically significant and did not change the severity of stenosis. Transesophageal echo is another tool which we use in evaluation of mitral stenosis. It is useful for demonstrating left atrial thrombus requiring anticoagulation or excluding left atrial thrombus prior to balloon mitral valvotomy. Patients with mitral stenosis in sinus rhythm or AF have larger left atrial appendage areas and significant decreased peak emptying and filling velocities of left atrial appendage, as well as decreased left atrial ejection fraction when compared to normal patients. Patients with mitral stenosis in spontaneous contrast have decreased left atrial appendage function and increased transmitral pressure gradients. As a larger left appendage area, decreased functions and decreased velocities have been correlated with thrombus formation. Some authors have advocated the presence of these predictors to help in determination of which patients will require anticoagulation. Intraprocedural transesophageal echo may be used to facilitate the puncture of an interatrial septum, confirm the valve morphology, and detect complications such as pericardial hemorrhage or mitral regurgitation. Transthoracic and transesophageal and recently intracardiac echocardiography have been described as useful adjuncts to percutaneous balloon mitral valvuloplasty. Echocardiography can predict which patients are most likely to benefit by the procedure, monitor progress, and identify qualification intraprocedurally and follow patients post-procedure. The pressure half-time method of determining MVA is inaccurate for several days after balloon mitral valvulotomy due to the fact that the atrial compliance takes time to change. Restenosis occurs by refusion of commissures. Higher valve scores and smaller post-procedure valve areas are associated with restenosis. Clinical and echocardiographic